TopMedTalk.
Well, hello. It's end of day one at the American Society of Anesthesiologists Anesthesiology 2021 annual meeting. I'm Desiree Chappell, your host, and I'm joined by my co-host, Professor Monty Mythen, Editor-in-Chief of TopMedTalk and Professor of Critical Care and Anesthesia at University College London. Hello, Monty.
Hey, Desiree. It is absolutely wonderful to be here.
It is wonderful to be here. I know we've been saying this a lot because we've had numerous conversations today, but it is wonderful for you to be in person here in San Diego, and for all of us, right? So many smiling faces. Everybody's so excited.
And I'm so pumped up. It feels like the beginning of the day. Because I think back at home it might be.
I think at this point, we're all a little bit in a daze, but that's all good. Professor Sol Aronson. Sol, I'm so glad you're here.
You've been saying that all day. Should I still believe you?
No, you should still believe me.
Then I do.
It's true. It's true. Guys, we've had some great conversations on TopMedTalk, a range of really interesting topics, and we'll do a little wrap up here in a little bit and talk more about those. But really important conversations with, some of the presenters here, key opinion leaders, and kind of diving right in, we have our next guest on TopMedTalk, but actually a major friend of the family of EBPOM and TopMedTalk, Dr. Ashish Khanna. Hello, Ashish. How are you?
Hi, Desiree. And I have to say that when I was coming into San Diego, I had set myself some personal goals where I'm going to be really careful. I'm going to just hide in my hotel, do my sessions, and not expose myself to any other human beings who are breathing around me.
How's that going for you?
It has. I have taken that away from part of my cerebral hemisphere now. I'm like, stop thinking about all of that. This is too good.
YOLO, right?
Yes, exactly. So super excited to be here and super excited to meet all of you. I was going to say just the two of you, all of you, in person, real life, shape and form. So
this last year we've had so many conversations via Zoom and our EBPOM meetings and things like that. It's the first time we've actually ever met in person. So
absolutely,
it is great. Well, just for our listeners out there, if you're just now joining us, TopMedTalk is a broadcasting arm of evidence-based perioperative medicine. Monty, I know you've been telling us all day, but one more time, tell us about EBPOM.
Monty, what's EBPOM?
It's just all you want to take this one?
So a group of us started evidence-based perioperative medicine 24 years ago, so next year is our 25th anniversary. Our mission statement is on our website, but basically it's trying to bring the world closer together to discuss perioperative issues. And more recently, we started our broadcasting arm, TopMedTalk, and that's what we're doing here today. Now, if you look around, because you'll be watching this now in our educational hub, please do have a look around all of the content there. There's on-demand content that is both video and podcast, and you can follow your way in and find over 1,500 different podcasts, videos, etc. And right at the moment, it is free.
It is free.
And how do you access this?
Well, of course, if you're watching this right now, you're on the live.ebpom.org. You can also find a lot of our conversations that we've had over the years. We've been doing this for a little while at topmedtalk.com. And Monty, we've had a lot of discussions about the topic that we're going to be talking about today, haven't we?
We have. We're going to go back to a favorite of ours, which is, I'm going to say intraoperative hypotension, IOH. But we're going to go beyond that, just to give a little teaser there.
That's right. That's right. We talk a lot about it, but I always love our conversations because I still see the excitement whenever, the group gets here and really starts digging in. And sometimes I'm like, wow, how did we end up there at the end of this conversation? We get deep sometimes.
Exactly. Well, one of the, I think, that puts the interest in this in perspective is... Recently, we were at our Ireland meeting, and a part of that, we went live to the European Parliament in Brussels, where two MEPs, members of the European Parliament, supported the launch of a document called Improve, which is all about improving surgical outcomes. And the main thrust of it was discussions around intraoperative hypotension, because part of it, as a sort of think tank that formed and produced this document, was you're telling us that there's loads of this thing happening and it's associated with harm. Can we have a bigger discussion about that? Does that make sense? They're sort of saying, am I making sense to you there, Sol? They were sort of saying
it does. I'm just amazed, maybe envious, maybe not, but amazed that Parliament decided to get into that discussion, into that space.
It's the European Parliament, and therefore you can have members of the European Parliament support the launch of a lobbying document that says that this is... So they're not there saying that Parliament has decided we're going to do something about this. They've said, we think that the European Parliament should listen closer. And we think that this group has articulated something that's worth listening closer to.
So do you think, Monty, this is one step closer to taking this to the general public? I've always advocated that we talk a lot about, say, cancer chemotherapy. It's out on TV and this and that. And we don't talk enough about perioperative hypotension to the general public.
And overall, the group, which is informed by patients and patient advocates, said you need to get over yourself. In other words, you need to be prepared to talk to the public about it. And that is a challenge that we need to talk through.
So, Ashish, that raises a really interesting question to go directly to the public. Once upon a time, a little bit still residual, awareness under anesthesia was sexy to talk about. We know it's not common. It's real and it's devastating, but it's not common. And yet that was a direct campaign to go to the public to sort of bring it up from the bottom. Is intraoperative hypotension worthy of that approach? It is common, and it's under-recognized.
Right. I mean, if we just look at the figures, I mean, it's way more common than intraoperative awareness is, especially the way Hollywood portrayed it, right? And, after a few movies came out, every one of my patients used to ask me in the pre-op area, will I wake up under anesthesia? That's the only question they had for me, right? No one ever asked me, will I be hemodynamically stable? Maybe the day I go under anesthesia, I'm going to ask the guys, please, this is my sweet blood pressure spot, keep me there, right? Don't let me be hypotensive. But that's me. The average person, they don't care. They go under anesthesia. They want to know who their surgeon is. They want to know if they'll wake up at the end of the procedure and if they won't wake up in the middle of the procedure. Is that because we're not educating people about it?
So is it that they don't care or they don't understand that they need to care?
They don't understand that they need to care. But the problem is, how much can we say?
Well, there's a segue.
So one of the...
How much can we say?
Well, that's a great thing. So one of the lead patient advocates in the group listened to the first presentations, and they got us to pause, and they said, hang on a second. I think what you're telling me is you've all got guidelines that are sort of universal that says part of your responsibility is to look after my blood pressure, my hemodynamic stability. That's what you do. You've then gone on to tell me that almost everyone is not hitting that measure. Yeah. And that increases the chances of me having long-term harm. I think we should talk about this. That's a reasonable challenge.
No, the logic is linear and ripe for discussion. When and how do we have that discussion in this country?
Are people willing to? I just find it so hard that we're willing to have that discussion.
And will the next patient ask me? I want to look at my intraoperative anesthesia chart after I wake up from anesthesia, right? Because if a few minutes of hypotension increases the risk of myocardial injury by about 30%, then great. Then my anesthesia chart is going to go to our friendly neighborhood attorney, and then that's the end of that. But I still feel that. Just for the fear of litigation or the fear of being in trouble, we're trying to not educate people. That is not the best way of doing this. Yes, we have to make people understand that there's a risk, but we are there to handle the risk, right? Are we willing to take that responsibility and do something about it?
Wow, we opened up so many interesting can of worms here. Let me grab one swim lane and just sort of go down that road. I'm going to sort of back off from the fear of litigation as cause, and just simply say a burden or responsibility to do our best, because we're all smart, we're all well-intended, and we're all trying to do our best. But sometimes people get hypotensive. When that happens, not from cause of bad behavior, but when that happens, do we have a burden of responsibility to tell our patients? Because if the data are what the data are, do we have a burden of responsibility to tell our patients? What are your thoughts on that?
It's a great question. again, if I knew how to word it appropriately, and if I knew I had the right audience, and I had some guardrails where I didn't have to say too much, I had to say just enough, then I would probably say it. It's like me, so I practice mostly critical care. It's like me having a conversation with the family afterwards saying, such and such issue is going on with your family member, they're not going to do well, right? It's a similar discussion. Your family member had hemodynamic instability in the operating room. There is a likelihood that they might have some renal injury in the days to follow. We're going to do our best in the perioperative period to make sure that that doesn't happen. And that's probably how I would word it. I don't know how it would go down, though, right? I mean, I haven't done it yet.
That's what the patients and patient representatives were saying that they thought we should do. They said that they thought we had, and this document's published, people can read it and the inputs, and they were saying, well, you have a duty of candor. You certainly do in the UK, in Europe. We have a requirement, a duty of candor to be open and honest about what happened. And they said, don't be fearful of coming up and saying, despite our best efforts, your blood pressure was lower than we'd hoped for periods during this. And as a result of that, we're going to track your kidney function closely, and we're going to let your family practitioner know that you need to be followed up.
But let me just introduce something else into all of this. Who has this conversation at your institution, at my institution, and at my previous institution? It's still mostly the surgeons, right? They will go out, meet the family members and say, oh, something happened. And I hope a lot of surgeons don't tune into this. Oh, something happened. Oh, the anesthesia team told me that the blood pressure was really low for a while. Or something happened. So it turns into more of a blame it on anesthesia. I'm the surgeon. I'm talking to you about this. Can we step back for a change and say, I am the anesthesiologist. I am going to talk to you about hypotension because I deal with it, and I will obviously take responsibility.
So we're going to take a time out for a second just in case people have just joined us. We're not suggesting that we should do this.
No.
We're suggesting that we've been challenged to think about it.
Yeah.
And I'm going to, I'll call you and raise you one. So I don't think this is a fault. I think this is a fact. There are risks associated with everything we do, including delivery of anesthesia. And one of those risks, let's just say, is hemodynamic instability. Despite our best efforts, despite our best intentions, we do what we can do to prevent that. We can talk about how to do that better, but we do what we can do to prevent this. And nevertheless, sometimes it happens. When it does, it's a fact, not a fault. So we should communicate that.
That's the message we were getting.
Yeah.
But, so let's move that on.
I was going to say.
You can look at that document. Desiree, where should we go now?
No, it was the improved document, right?
Exactly. We can put the links associated with it.
I mean, I think it's an important conversation that we continue to have. But, one of the things that we wanted to dive into, and I had to really keep Monty from pulling out the roll-up banner that that talked about the pokey consensus statements on blood pressure. But Monty, we've had a lot of discussion about thresholds and where that number is. So let's dive into that just a little bit.
So the various different consensus efforts, the common number that's out there is, we've discussed it repeatedly, is a MAP of 65, is a pragmatic threshold that we should try and keep our patients above. Yet to be completely determined if that's a great idea or not, but it seems sensible and pragmatic. And one of the big debates, and it took a long time, you were in the London pokey one, Sol, was surely it's not that simple. Surely there can't just be a magic number. It's much more complex than that.
Absolutely, and I'm a big proponent of the fact that there is no magic number. But I also feel that do we really know what our patient's true baseline is? So I often question the baseline that's reported to me in the EMR. Patient goes to a doctor's office, is super anxious, gets 3 high blood pressures recorded. Is that the real baseline? Is the baseline the pre-op holding room hypertension, again, the anxious patient coming in day of surgery, right? Or is the baseline what I keep to just do my day-to-day activities at home over a period of monitoring of, say, 10 days before surgery, right? Sounds very ambitious, but in this era of precision medicine, where we have these watches here checking on my heart rate and rhythm, why can we not have everyone's blood pressure kept track of in some sort of smart device? I come to the anesthesiologist, I hand them this device, say, this is my baseline, can you keep me 10% of my baseline? Sounds futuristic, but that will be the day when we will keep people close to their physiological normal, not with a map of 65.
I love it. I don't think it's that far-fetched. I don't think it's that far-reaching. I agree with you. The term baseline is so nebulous and hard to wrap your arms around, though I think it's relevant. I think it's important, whatever the heck that is. And I love your idea of using remote patient monitoring tools to help us get a better handle on that. That should be a part of the anesthesiology deliverable.
One thing I was just going to say really quickly, because I have this conversation a lot. We always talk about what is our patient baseline. And until the time that we have that, like there are a lot of places in the EMR, you can actually go back and see like the historic, as long as they've been seeing physicians within, their My Chart, we have all of those historic blood pressures. And, you can, even though take it in one particular
doctor's
instance.
Office blood pressures.
Yeah,
doctor's office.
They are. But in one particular instance, you may have it. But if you have 2-3 years of data in there, surely you'll kind of get at least an idea of it.
Right.
That's something we're doing on a practical matter.
I'll identify the guy who's chronically hypertensive and uncontrolled and lives at 180 over 120, yes.
Very easy.
But I probably won't identify the guy who's borderline and, maybe when he goes to bed at night, his pressure's fine, but, when he walks around and does stuff, his pressure's high. So I struggle with the concept of baseline.
So what is the definition of hypotension in your world?
Well... Way to put me on the spot. I thought the difficult questions were going to him. But anyway, in my world, the definition of hypotension is either a map less than 65 or a map where I see that I am struggling with maintaining hemodynamic stability. So if I need to provide someone vasopressors unnecessarily where, they shouldn't have been on vasopressors, or I'm having to give them fluids just to maintain a urinary output or keep their lactate normal. I'm sorry, I don't have any other great measures so far. I don't know, these are not great measures in general. That is sort of the map I go by.
This sounds to me like the journey we traveled with shock and septic shock. Because we eventually got to a place where having an okay blood pressure doesn't mean you're not shocked. If you had to give a whole load of extra fluid and you had to start a vasopressor, you're shocked. You've just put the blood pressure back to a number that's making people happier.
Great physiology that we're delving into. And I remember way back when I was younger, I had hair then. Cardiologist, Sanjay Kaul, brilliant, taught me the sort of adaptive response to those shock states, where at the organ level you're maximally vasodilated, all your capillaries are recruited, and you're doing the best you can to maintain perfusion. In ischemic shock, you have all those capillaries maxillary dilated. And there's nothing more you can do to dilate them more. In hypovolemic shock, not all the capillaries are awake. It's a winking and blinking phenomena. And so when you give a vasopressor, you're squeezing those that are open, but you're not recruiting those that have already not been a part of the perfusion cycle. So it's complex.
So to that point, part of the sophistication of the conversation as it progresses, and there's been some great editorials written about this recently by others, not here at the moment, but you can look them up, is how it's obvious how you become hypotensive must be an important discussion point. It's got to be relevant, because if you go back to that pokey one paper about the physiology of blood pressure, if you maintain volume and flow, it's not clear that blood pressure threshold is as critical if you haven't maintained volume of flow.
You could be vasoplegic and euvolemic.
Okay.
Yeah, I mean, sorry. I mean,
No, go ahead.
these are great points. And you know, the etiology of hypotension is really, really important. Unfortunately, not studied well in all of the retrospective data, which is close to 1 million patients or more that have been published with hypotension. Right? We need to do it. I have a feeling that we will see clearly different signals and risks of harm if we really stratify people by age and etiology. I mean, we know the young patient who comes in with trauma and loses 2 liters of blood and is also hypotensive does well. Maybe does have a little bit of AKI 2 days later, but then his kidneys recover, his or her, and they're back to normal. I mean that is trauma resuscitation. By the way, trauma resuscitation, we also don't try and drive the blood pressure up all the way, right? So etiology matters.
Are they back to normal?
Not right away.
No, but
Right.
but I'm begging the question. I'm forcing us to sort of, based on the metrics that we use to determine back to normal, but are those sensitive enough to determine if they're really, really
So
back
do you
to
think
normal?
we should do routine troponin surveillance in patients who bleed 2 liters of trauma?
Should we?
Should we?
You first.
And what are we going to do about it if we identify myocardial injury
Well, that's
in
the
a
question. It's one of the
35-year-old?
questions, isn't it?
Okay, so now we're at risk in this particular attempt at flushing out some issues to have said nothing really useful so far at all, apart from we don't know what's going on. Is there anything we can do to help?
One of the questions that I was going to have is, you know, we talk about treating so we know that there's a problem, we're going to treat it. So, you know, we push the flow, fluid, you know, pressure thing. Is that still what we need to be talking about?
I think we also need to talk about other stuff. And I'll bring up a recent personal favorite, which is abdominal perfusion pressure. I don't think we talk about it enough because we don't routinely measure intra-abdominal hypertension. We only measure intra-abdominal hypertension where we feel there's an obvious problem. And those people are clearly, you know, they're the ones who need a emergency open up of their belly to relieve that pressure. I think if we measure that more frequently, we will start finding that no two people are alike in terms of intra-abdominal hypertension and actual abdominal perfusion pressure that's perfusing the kidneys or the gut. That's a little bit of a personal favorite that's coming through. I'm actually doing some work on it, and I've found some interesting data in the cardiac surgical patients that we've gone around and presented. But everyone has their favorites, and I think that's one. And I'm sure, Sol, you have got a...
Well, I don't know that I have a favorite, but I'm thinking of the question that you posed, Monty, and I'm going to, bear with me, I'm going to stretch here a little bit, but perhaps when we think about these things, what we can't start with a commonality of agreement. And I think we can all agree that low blood pressure, whatever that is, define it, is a bad thing. And it's better not to have it than to have it. How it gets there, how we manage it, what we do about it, how we communicate, those are all interesting conversations. But I think we can all agree it's better not to have it than to have it. So if you use that premise and then switch that to the analogy of anemia, and what we've learned is, you know, we talked for years and decades about transfusion triggers and whether or not you could tolerate or not tolerate a certain threshold, you know, hemoglobin level, and what to do about it and how to treat it. And those are all really important conversations. But what we also appreciate, it's better not to be anemic. And so if you can fix that upstream and not have to get to that point in the algorithm where you have to do a decision sort of analysis, that's just better. And perhaps the hypotension story is best served by that logic. So what do we do? What can we do to prevent that junction in the decision tree to even having to be confronted? I'll pose.
I'll give you an example there, so which I think in a cardiothoracic world we all would have lived. If you're inducing anesthesia and about to do intubate and do positive pressure ventilation in somebody you know has got critical left main stem and and aortic stenosis, you are watching that blood pressure like a hawk. You've got your A-line in before they go off to sleep, and you are doing simple maneuvers to mitigate the risk of a critical drop in blood pressure that you've been trained you will probably not get the patient back from. So we know we can do it. Mm-hmm. We know we can preempt, if you should. You know, we're doing that the right way to preempt it, but it's achievable.
Well, again, brings me back to the point of the etiology of hypotension. We can preempt and predict a lot of hypotension that is not because of surgical misadventures, but clearly surgical misadventure is difficult to predict. Even the most experienced surgeons sometimes don't know that the things are going to go wrong, and when they go wrong, they go wrong. So sometimes that junction happens and just happens, and then, we've got to respond to it. Other times, yes, I do agree. I think it's obviously always better to prevent it than to react to it.
Yeah. What was it? One more thing we wanted to touch on, didn't we?
Very briefly, we keep promising that we need to do more about it, and we've described it in the past of one of our dirty little secrets. Once the patient leaves a high care environment, it would appear that even in some of the most well-resourced places in the world, we don't know if they're getting hypotensive episodes or not.
Absolutely, and I'm out of adjectives and expressions to describe how much I've said about this. And interestingly, I am at an institution that has had continuous hemodynamic monitoring for floor patients for the last 4 years. And I can tell you that I have taken a deep dive into 15,000, 20,000 patients now. And I've seen all sorts of blood pressure fluctuations that were picked up by continuous monitoring on the floor. And have obviously not been picked up by every 4-hourly nursing checks, right? And then some of that data has already been published. And the next step, obviously, is to say, well, so what if my patient is hypotensive on the floor? Does that make a difference in outcomes? And clearly we need to do some sort of prospective randomized trials to say, does improved monitoring for the floor patient truly make a difference? So the question is twofold. Will we detect more hypotension? If we do, will we overcome alarm fatigue and go in and fix the hypotension? And again, that brings me back to the point. My patient on the floor is watching TV and having their evening supper, and their MAP is reading 63. What is the poor floor nurse supposed to do? Is she going to call the surgical intern? And he's going to say, well, I have nothing to offer. Are we going to start a vasopressor, transfer that patient to the ICU? What are we going to do? So I'm sorry I've looped us around.
No, these are perfectly excellent points.
Yeah.
But there is a problem outside the PACU and outside the walls of the ICU. It's a huge problem, not just with hypotension, but with respiratory depression as well that goes undetected, and we're doing a little bit of a disservice.
But what we do know to counter, balance the argument that the patient is watching TV and talking, to their wife or son or daughter, that we do know that the prevalence of post-operative adverse events, MI, are most prevalent at day 2 through 4. And so some of them aren't doing okay, even though they're watching, Jeopardy or, The Price is Right.
So I've cited it before, and it's published now. Work done by some of our colleagues down in Australia. Guy Ludbrook is the name I would most immediately associated with it. And Bernard Riedel, doing a very neat experiment whereby they looked at the METS calls, the emergency calls, which are often triggered by hypotension and instability. And they looked at them in their major elective cancer surgery patients in a specialist centre. When they did what they usually did, which was to send most patients back to the floor, there was only 1 in 20 patients who triggered an emergency call. So they then took a period of time where they kept everyone in PACU for 24 hours. And 1 in 4 triggered an emergency call. And when they triggered it, they prompted more interventions with, hemodynamic corrective agencies. But also the important thing is outcomes got better. So it appeared as though they did matter, if you see what I mean. There's some kernel of the possibility, the fact that a bigger trial would perhaps underline the fact that it's going to make a difference.
I mean, absolutely. We know that rapid response calls or code blues don't happen out of the blue, right? They're always preceded by, if you look back, there's a period of sort of an aura or a change in vital signs that's happening, a pattern detection if you go back.
Yeah.
But I always say it's like flying a plane without a flight data recorder, right? The plane crashes, at least you can go back and fix those things that the crash doesn't happen again, right? But right now what we're doing to our floor patients is that they crash and burn, they come to the ICU, and then we're like, oh, maybe he has a PE, maybe he had an MI, maybe, I don't know why he stopped breathing on us, right? And we do a whole gamut of investigations because I don't have a flight data recorder to go back and see what was transpiring, right? So we need flight data recorders for our patients. And again, patient education. If I had informed family members and patients that you were not being monitored on the floor, would everyone be happy with that?
Yeah. All right. So the Guy Ludbrook piece, all that has come out. We know about intraoperative hypotension. where are we going? Like, where are we going in this? What's coming down the pike?
I think we're going towards a more predictive, proactive rather than reactive approach. We're hopefully going to a culture change where anesthesiologists take responsibility for their patients both within and outside the walls of the operating room and the PACU and truly say, I take ownership of hemodynamic instability and I'm going to fix it.
I mean, are there programs that have come out of the Guy Ledbrook and the HDUs and things
Yeah,
like
there
that?
are. And they've done pilot projects in Australia now to test the concept of a sort of enhanced care post-operative environment. And that has led on to, and the one project that I'm involved with Mike Grocott and Guy Ledbrook is a co-author on the grant applications, is this concept of continuous iterative perioperative holistic evaluation of risk, which is CIPHER. In other words, can you use all the information available live to modify your risk profiling and identify the patient that will go on to deteriorate on the floor? And that's going to take years to mature, but that work is ongoing.
Yeah.
You know, if you get to the end of the case, you might have been predicted to be low risk. You've now become high risk because of what you said. You needed a vasopressor infusion to keep your blood pressure up. I know when you woke up in recovery, you looked fine, and now you're going back to the floor. But actually, there's a much higher risk now that that's not going to be the way it plays out. That's a lot of work to do, but that is the journey that we're on.
Yeah. Ashish, we talked about this earlier, like, in the last conversation of the day, I was like, it's going to be great. And it was.
Hopefully
Wonderful
it was, and hopefully I still look pretty, and my perfusion pressure is okay, so we're all okay.
All good. Gentlemen, thank you so much for this lovely conversation. I know we're going to be talking more about it in the future. Again, want to thank the ASA for the support and partnership to be here this year in the exhibit hall. It's the end of day one. We're going to do a little wrap here in just a little bit. Stick around for that. But we do want to say thank you also to all of our sponsors of EBPOM and TopMedTalk. Without you, we could not do this. We could not have these conversations. We could not be putting this information in the hands of people around the world. So thank you, thank you, thank you.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.